Hello, everybody. Welcome back to the show. This is the Science Dispatch podcast. My name is Cameron English. That handsome young man over there, as always, Dr. Chuck Dinnerstein, Director of Medicine at the American Council on Science and Health. Chuck, what's going on?
Not a blessed thing. How are you, Cameron?
I'm terrific. I'm excited. We've got we brought the big guns today, I guess is what we can say. We're joined by Dr. Jeffrey Singer from the Cato Institute, Senior Fellow in the Department of Health Studies. You're great. Your work on drug prohibition, opioid prohibition, on tobacco harm reduction. I usually go to you, not to sound like too much of a fanboy, but if there's a question I have about health policy, I usually go and I say, what has Jeff said about this? So it's quite an honor to speak with you, and welcome to the show.
Well, thank you, and that's very kind of you to say that. So
we wanted to talk today about harm reduction in a broader sense, talking about drug policy, drug prohibition, but you're best known, I think, for this idea that's called the iron law of prohibition. So maybe you can introduce people to that concept and then talk a little bit about how it applies to people falsely call it the opioid epidemic, but maybe the fentanyl epidemic, like the real public health crisis that we're seeing. Maybe we could start there.
Yeah, well, it's not. I don't want to get credit for that idea. That idea's been around since the 80s. I think it was an article by, blanking on the first name, I think it was Richard Cowan, C-O-W-A-N, in National Review, in which he coined the phrase the iron law of prohibition. And it was an article about cannabis prohibition. But it caught on because it made a lot of sense. Economists kind of latched onto it as well. Basically, the principle is, the shorthand is, the harder the enforcement, the harder the drug when it comes to prohibition. And so, for example, during the times of alcohol prohibition, they weren't the smugglers, the bootleggers weren't smuggling in beer and wine. They were smuggling in the hard stuff, whiskey, and that kind of thing. It's because the risks of prohibition and the enforcement incentivize the people who are bringing in the prohibited substance to come up with more potent forms, which, besides being usually easier to smuggle in smaller sizes, once they get smuggled in, they could be divided into more units for sale. So it makes it worth the risk. In fact, the economists talk of what's called the Alchian-Allen effect. In case you want to Google it, it's ALCHIAN-ALLEN. These are two famous economists, and they didn't talk about it with regard to prohibition. They just talked about it, the effect when it comes to making things more difficult. The effect on the strength of what it is. So anyway, that's why. And a real life example that happens today in the iron law of prohibition is when people go to football games. Everybody's tailgating in the parking lot, drinking beer and wine, but you're not allowed to bring any alcohol into the stadium. You don't see people commonly smuggling in six-packs. They smuggle in usually in flasks, tequila or vodka or whiskey or whatever. That's the iron law of prohibition in real time. So what I point out is that over the years, as we continued to clamp down on these substances that I have a book called Your Body, Your Healthcare, and I write about this. I think it's chapter 6 in the book, and the title of the chapter is The War on parentheses, some, close parentheses, drugs. Because it's not a war on drugs, it's a war on specific drugs. There are a lot of drugs that our government hasn't declared war on that in many cases are much more dangerous and cause much greater health problems like
I think
alcohol.
Your co-author Josh has written on alcohol in particular.
Right. So because of prohibition, for example, originally with cannabis, the THC concentration of cannabis over the years has gotten stronger and stronger. So you hear people saying, the cannabis you buy now is not your father's cannabis from the 70s, is much stronger. Assuming your father's a baby boomer. And although in the states where it's legal recreationally, and where I am in Arizona, it is, you can go into a shop and you could say to the retailer, look, I'm a lightweight. I haven't tried this stuff since I was in college. What do you recommend for sort of a beginner? And they're happy to show you their, all their different strengths and different options. Just like when you go into a liquor store, which is a legal drug dealer, it says on the bottle 45% alcohol, 30% alcohol. You could kind of choose what you want. Maybe you want to water it down a little bit. Anyway, so that's why cannabis has gotten stronger. It's why, for example, cocaine, many people think that we wouldn't have had crack cocaine if it wasn't for prohibition, because that incentivized a way of making it smaller, easier to smuggle, and actually cheaper to sit, so you could expand your market. During the late 90s, early 2000s, a common drug of choice for people who wanted to use either recreationally or maybe even they were self-medicating for either a physical or mental issues was what we call diverted prescription pain pills. These were prescription pills that found their way into the black market, either stolen or maybe a patient was a malingerer, got a doctor write a prescription, and sold them on the street. All sorts of things, robbed grandma's medicine cabinet. So they got diverted into the black market, and a lot of people were using them. And then when we got this false narrative that it was the doctors hooking everybody on prescription pain pills that were creating the overdose problem, we made it more difficult for them to prescribe by literally intimidating them and passing all sorts of laws and regulations, making it intimidating doctors into undertreating pain. And then as a result, the people who were used to accessing diverted prescription pain pills saw the supply dwindle, which quickly was replaced with first heroin. And then, of course, fentanyl. It was discovered by drug dealers that if you add a little bit of this synthetic opioid fentanyl to heroin, you could make the heroin more potent and smuggle it in smaller sizes. It'd be easier to sneak in and also extend your product. You could sell more. So it started appearing mixed in with heroin around 2012. And then when the pandemic hit and we had supply chain problems because you need to make heroin. First, you got to get the opium plant and you got to extract the morphine, which is the natural opioid, the opium product, and you got to convert that to diacetyl morphine, which is heroin, using acetic anhydride, which is used to make a lot of things, including aspirin. Well, there was a shortage of acetic anhydride because of all the pandemic with the border closures, et cetera. There's also getting more difficult to transport opium. So the drug cartels quickly said, well, why don't we just switch over to fentanyl, because the supplies for that are readily available. And in fact, we don't have to rely on growing plants. We could do this in a laboratory in a basement. And so fentanyl pretty much replaced heroin. Now it's making a comeback, and we're starting to see heroin make a comeback again among the mix. But we're also seeing another drug appear called nitazines. And I wrote about this actually with Josh Bloom a couple of times. And nitazines are a synthetic opioid, like fentanyl is, not chemically the same. Fentanyl is a derivative of piperidine, and nitazines are derived from benzimidazoles. And Ciba, which is now called Novartis, developed it in the 1950s as a synthetic opioid type pain medication for reasons that I don't know. They never decided to bring it to market, but there are many variations of it. And it started appearing in Western Europe, UK, Canada, US around 2019. And we're starting to see more and more of it. A lot of toxicology labs, when they're doing analyses for drug overdoses, don't check for it because it's kind of not high on their radar screen yet, although more and more are. And there were recently some high-profile news stories about a month ago or so in Houston, Texas, about two 20-something-year-old friends who, about a month apart, died of an overdose due to nitazine. They thought they were purchasing a substance on the black market one of them thought he was purchasing an Percocet, oxycodone. The other thought he was purchasing Xanax. In both cases, they were either completely with nitazene or adulterated with nitazene. But nitazene could be up, in that case, the type of nitazene it was, because there's several types, was described as being 43 times the potency of fentanyl. But as Josh has told me, Josh is a chemist. I'm not. And he said depending on what analog you use, it could be up to 1,000 times more potent than fentanyl. And it's going to even be harder for law enforcement to interdict the ingredients that these labs use to make nitazenes, because benzimidazoles are very, very broad spectrum of medications. They're used to make, for example, antihypertensive medications like losartan or omeprazole, a very common antacid, and antifungals. So the ingredients used that to make nitazenes out of benzimidazole it's going to be harder to track because they're being used for so many legal, commonly used medications. So that's the next frontier.
So Jeffrey, let me ask this, because we've talked about Cameron and I have talked about this problem a bunch of times on the podcast. Do you see any kind of solution outside of prohibition for let's call it addictive drug use?
Yeah, I think we should treat all of these arbitrarily prohibited drugs the same way we treat alcohol and tobacco, which are not prohibited.
So
we experimented with prohibiting.
Legalize them all.
Yeah, and you could have regulations, like, for example, age restrictions. Minors don't have the same rights as autonomous adults. They're not autonomous adults necessarily. We can get into a lot of legal philosophy about when you reach the age of majority and consent, but the principle is you could have age restrictions. You could have restrictions regarding use in public places, especially if you're operating a vehicle or something like that, where if you're impaired, you could jeopardize other people's lives. I'm fine with public nuisance laws as long as they're reasonable and as long as they're enforced reasonably. So, I mean, it's already in most cities, you're not supposed to drink alcohol in public, except in New Orleans and Las Vegas, to my knowledge. But otherwise, you take it inside. You shouldn't be loitering around the streets and things like that. So I'm okay with rules like that, but the main thing is, we experimented with both alcohol and tobacco prohibition. I cover tobacco also in the book. In the early 20th century, many states had totally banned tobacco, and they found that it not only it just stimulated a black market, and then by the late 20s, the states that did, one by one, said, we're not going to win this thing. They were practical in those days. Let's just legalize and tax it, and that's what they did. So I think we should do the same thing. And not only that, it makes it safer, because during alcohol prohibition, when people got bootleg alcohol, a lot of times it was adulterated. There were many deaths and terrible illnesses attributed to bootleg alcohol. So, and of course, it stimulates crime because the people who are selling it, you can't use lawyers to settle arguments with competing distributors. You have to use guns. So there's a whole lot of downsides to society by making it prohibited. You just have to accept the fact that whatever the substance is, some people are going to develop unhealthy relationships with it. Most people won't. Most people don't become addicted to alcohol, but some people do. And when you realize that it's a health, particularly a mental health problem when you develop the addiction, and as you know, addiction and dependency are two different things. But addiction is a compulsive behavioral disorder, actually. So when you develop an addiction to a substance, if it's legal, somehow we tend to treat people more compassionately. I mean, there was a time when we looked down on people who had an alcohol problem. Now we tend to be much more compassionate about it. We look at it as, we sympathize with the people. We try to get them help. And the other thing we could do, and which we do with these legal substances, is we practice what's called harm reduction, which is a term that came out of actually Liverpool, England in the 1980s, when there was a wave of HIV spreading throughout England from needle sharing. And a group of people in Liverpool saw this explosion of HIV in Edinburgh, Scotland, and they began giving out clean needles and syringes and bleach and explaining to people who were using IV drugs that you shouldn't share needles and how to clean them if you're going to reuse them. And Liverpool never saw the epidemic of HIV that Edinburgh did. And they coined the term harm reduction. But nowadays that term has a lot of baggage with people who are prohibitionists because they interpret that as enabling, like you're endorsing it. But in fact, and Chuck, you'd know this, as doctors, particularly in affluent societies like the U.S. and Western countries, most of what we do is harm reduction. And, thank goodness we've eradicated most deadly infectious diseases. You don't see that many people dying from work accidents anymore. We're not getting, eaten by tigers and lions. So a lot of health problems are related to our dietary choices, or whether we eat or whether we drink too much, what kind of activities we choose to engage in. So, for example, as a doctor, if we have patients who, they're getting they got high blood pressure, their cholesterol's too high, they're showing signs of borderline diabetes, and we know if we could just get these people to change their diet and go on an exercise regimen that we would recommend, and maybe adjust some of their lifestyle choices, their behaviors, they wouldn't need any medication, and we could really get them on a better trend line towards longevity. But for whatever reason, either they like their lifestyle choices or they don't believe they have the willpower to give up some of these things for whatever reasons, they won't. So it's not like we're saying keep overeating and keep drinking lots of alcohol, et cetera, et cetera. We say, okay, let me give you some things to reduce the risks that your choices are putting you at. So let me put you on a blood pressure pill to get your blood pressure to a safer range. Let me get your cholesterol down. Let me maybe put you on metformin to get your A1C in a better range. I'm practicing harm reduction. I'm not endorsing their decisions. In fact, I'm trying to convince them otherwise. But I'm also, as a doctor, more concerned about them living longer. So,
hey, Jeff, can I ask you a follow-up just to go back to the legalization
please.
for a second? So, and I bring this up because there's different perspectives on what it would look like. So in your ideal world, you're ruler of the planet for a day. What does legalization look like? Does it look like you go into CVS and here's the heroin shelf, and if you have the right ID and you're old enough, you can buy it just like you can a bottle of vodka? Or do we go to sort of a prescription model like they have in Australia with vaping, right? Do you need a doctor's slip?
In my ideal world, if you're an autonomous adult, and I cover this at length in my book, Your Body, Your Healthcare. If you're an autonomous adult, you shouldn't need to get a permission from another autonomous adult to choose to engage in an activity or consume a substance where you're not hurting anybody else. You're not violating anybody else's rights. So it's not their business. So in my ideal world, now a lot of these things will be decided also by the marketplace. So maybe a family store like CVS may make a decision that we don't want to market those products in our store. They may, I think some CVSs probably sell alcohol. They have an alcohol aisle, but others don't. So these would be decisions. I would imagine there'll be stores just like there are cannabis stores. There'll be maybe even the same stores where you buy cannabis would sell other drugs. But I don't think you. And by the way, there's a white paper I wrote with my colleague Michael Cannon, the director of health policy studies at Cato, I think it came out in 2020. It's called Drug Reformation, and that was actually inspired by your question, Cameron. I started thinking, gee, wouldn't it be if I lived in Libertopia and all of a sudden, people can go into a store and buy some heroin and use it, in their house so nobody else is affected by it. And they don't need a prescription. Wouldn't that be odd that you're going to have to get a prescription for Percocet or Tylenol number 3, but you could buy heroin over the counter? Wouldn't that be sort of cognitive dissonance there? And that's what got me thinking.
Yeah.
So then we did some research, and we found that up until 1951, the FDA had no say over what's prescription only and what's over the counter. Those were proprietary decisions made by the pharmaceutical companies, largely based on their assessment of what's the liability and reputation risk. So, if they made a complicated pharmaceutical and they thought, somebody's going to use this the wrong way, they're going to have a terrible reaction, we're going to get sued, our reputation. So we're going to say to pharmacies that we supply this to, you cannot sell this, that's the contract. You cannot sell this unless they have a prescription from a healthcare practitioner, and that kind of gets us off the hook liability-wise. So that's how it was. But then in 1951, Congress passed the Durham-Humphrey amendments to the Food, Drug, and Cosmetic Act and said from this point forward, the FDA decides. And of course, as we're learning now with all of the controversy over the CDC and the FDA now, no matter who's in charge, it's impossible for a government monopoly agency. You could have the angels there with the best of intentions. It's going to become subject to political and special interest pressures. And it's a big target. In fact, special interests love it when it's all in one place. If you had 50 different agencies for each state, that's harder for them to cover. It's much easier to put all your special interest pleading in one location, which would be Washington. So I've argued that if we got the federal government out of this and let this be up to state and local communities and let the pharmaceutical companies decide what they want to make prescription only and what over the counter, it would be a lot. Everybody's autonomy would be protected better.
So if we have, it's a property rights argument then, sort of like a Milton Friedman-esque, I own my body, I therefore get to determine what
absolutely.
I put in. That's where you're coming from? Okay.
It's actually a John Stuart Mill-esque.
Yeah, it does. It goes back to on liberty for sure. Yeah. Although I don't know, maybe I could be wrong. I have my doubts that he would say, yeah, heroin's fine. Like, I don't know, but.
Yeah, he
was? Okay. Okay. Good to know. So my follow-up then, based on this property rights concept, if I own a small business in Burlington, Vermont, for example, and there is a party of homeless people using injection drugs in front of my storefront, do I have the right to remove them?
I think so, yes.
On the same grounds? Okay.
Yeah, I think that they're.
And the reason I asked, just a quick follow-up, is I hear not all of them, but there are some very prominent harm reduction advocates who absolutely lament the idea of the police coming around and cleaning up a homeless encampment. And they seem to have no concern for the property rights of the store owners. Okay.
Yeah. And they're not necessarily libertarians, by the way.
Yeah, that's true.
Libertarians and a lot of progressives kind of align on certain issues like drug prohibition and harm reduction. So a lot of times we're kind of seen in the same venues and oftentimes taking the same position, but we come at it from different angles. So I think you got to respect the property rights of the property owners. And so that's why I have no problem with enforcing so-called public nuisance laws. If you're going to, including, a commercial street where you're clogging up the traffic on a commercial street that the people in the community are trying to use to do business. Take it somewhere else. I have no problems with that. In fact, as you know, Amsterdam, they were pretty good at this. They both sex work and cannabis have been legal there for years, but they sort of have designated areas, at least for the sex work. There's the red light district, and then there's another area for streetwalkers. And if you're caught street walking outside of that area, the police gently say, you're not supposed to be here. You know where you're supposed to go. Would you like me to give you a lift over there? Because that's where you need to conduct your business. You can't conduct it over here. So I have no problem with those kind of regulations as long as, as long as you don't have to necessarily use a gun to enforce loitering law, an anti-loitering law. You could use more. In fact, I have to think about this further, but just like we have different branches of the police, like the people who do traffic and parking meters, and oftentimes they're not armed, except maybe like in a taser for self-defense, because that's not their focus. Their focus is on traffic and parking violations. I could see having like a branch of the police force focused on that kind of, getting people get the camps, the tents off the streets, make sure they move it to the area of town where camping is allowed, that kind of thing.
So, Chuck, you can jump whenever you want. I just keep thinking of questions that I want to ask. The related issue, at least for me, is the health risks of drug use itself. So I'm curious to get your take on this. Again, a lot of the harm reduction folks that I've listened to or read, they seem to take the perspective that drug use in and of itself, if it's properly regulated, if the substances are pure, if people have access to health care, it's not all that bad. And I find that a little bit skeptical, having talked to a few doctors, a few toxicologists, like chronic heroin use, even if it's the pure stuff, whatever you want to call it, it's still quite harmful. So do you come down as drug use chronically is okay? Would you? Okay.
Now, some people may develop certain organic sensitivities, but actually, chronic opium use, heroin is just a kind of opium, is not nearly as harmful as chronic alcohol use. So we allow that, and chronic tobacco use. But I know long-term opioid use can reduce some of your gonadal hormones, which could have downstream effects like osteoporosis. I'm not aware of any evidence otherwise of any organ damage, and it's still controversial whether it could even affect your brain in any way, aside from you being dependent on it. Are you aware of any studies showing organic damage from long-term opium use?
Is that a question for Chuck? I mean, there's the obvious
constipation.
There's the obvious overdose risk. That still is a concern.
Of course, but I guess that's less likely when it's it's a market.
Yeah,
it's free where you can know what you're taking.
Harm reduction. A lot of the acute diseases that we associate with drug use would theoretically go away. The endocarditis. I mean, all the infectious diseases associated with non-sterile needles and all the rest would presumably. I can't imagine that they would disappear, but their numbers would be significantly decreased across the board. Though I'm having a tough time from my clinical side. My rational side says you're 100% right, Jeff. My clinical side says I'm not sure that it's completely harm-free, and I'm not quite ready yet to take that final step and say, yeah, let's go down that particular road.
Well, it also depends on the drug. So cocaine, I would argue, is more dangerous, okay? Because if you use that regularly, you can end up giving yourself a heart attack or a stroke because it raises your blood pressure sometimes to very dangerously high levels. So that could be more dangerous. My understanding from reading people like Carl Hart and Maya Salovitz is that the majority of cocaine users give up cocaine not because somebody had an intervention with them. It's because as they get older, they find they just can't keep up with it anymore. It's exhausting them. And they just make a decision saying, I can't do this anymore. I'm getting too old for this.
Well, we said this before. The things that are fun when you're 30 are not so much fun when you're 50 or 60.
Yeah, another interesting fact is, and this is all documented, the great majority of people who are addicted to illicit substances, by the time they hit their mid-30s, on their own, quit. They either, auto, taper, and that kind of thing, without rehab. They reach a point in their life when they've hit a crossroad and they say, I don't want to do this anymore. So that's interesting also. So there's a lot still we need to learn about substance use disorders anyway. There's a lot that we don't know, and a lot of it's based upon, myth or or folklore. But generally speaking, I would say alcohol is more dangerous than opium because alcohol, we all know, causes all sorts of organic damage, and it could also cause cancer. Cocaine's more dangerous than opium. Methamphetamine similarly could also give you a stroke or a heart attack. The stimulants are probably more dangerous than opium. But again, when they're legal, then you are able to, a couple of things. Number one, you're able to get the dose and purity that you want.
Quality control.
And people, like with alcohol, they, on their own, they spontaneously, they start sharing information with one another about how to use things more safely, how to avoid complications of using things. I mean, a designated driver is a form of harm reduction for alcohol. And a lot of that, spontaneously developed without having the government require it. A lot of people just said, I don't want to hurt anybody, so who's not going to drink among us tonight? You'll be the designated. So those are the kind of things that happen when you don't have to be afraid of getting caught.
So quick follow-up then, because you're right, relative to alcohol, it may or may not be as harmful. Alcohol does kill a lot of people. But I've heard from, I think, people that would mostly agree with you. So for example, Jacob James Rich at Reason, who I had on our other podcast, he was happy to concede that if you legalize these substances, their use is going to expand dramatically. So maybe what you're saying is right. People stop on their own. It's not going to be as harmful because it'll be regulated. You'll know what's in it, and probably more importantly, and not what's not in it, and so forth. But if the population of people using expands, doesn't that mean the risk is going to increase to a certain extent? And how do you mitigate that, or do you have to?
I think same thing happened with alcohol. The arguments against ending alcohol prohibition was you're going to have more people drinking, and you're going to have more people developing alcohol use disorder. And actually, when prohibition ended, there was a spike in that, and then it leveled off. And now, of course, we're learning recently that interest in alcohol is dropping dramatically, particularly among the younger generations. But you just got to, in a free society, it's going to get messy. Freedom is... In a free society, people are going to do things. They're going to make mistakes. They're going to do things that you may not want to see. That's the price you have to pay for being an autonomous adult in a free society. So I wouldn't argue that. I would say probably use would go up, but over time, use may actually come down or at least level off.
Yeah. That's interesting. I'd be curious to see. I mean, the only way to really do it would be to do it and see what happens. The concern I have, though, is that, and I'm sad to say this, people like you don't run the country. So there's a lot of people who might get some form of legalization over the goal line, and then you seem to be acknowledging that there could be some fallout from a policy like that. So what my concern?
You got to be honest. If you're painting a utopian picture, you're going to hurt yourself in the long run.
Yeah, so. and I appreciate that. But what I'm concerned is going to happen is a lot of the things we were talking about a minute ago, right? Like people congregating on the streets, people defecating on the streets, everyone's seen the videos from San Francisco and all that. And we can talk about, those specific cases if you like. But that's my concern is we'll get the legalization, but then we won't get the related policies we'll need, like appropriate enforcement or people. And I don't know what you think about this, but if someone is, frozen on the street because they're high on heroin, is it appropriate to get that person into treatment even against their will? Because that to me looks like a disaster. That looks like a threat to public safety and public health. And that's my concern.
Yeah, I personally, and I write about this in the book too, I don't think from a ethical standpoint, I don't believe in coercive treatment. But there's also a lot of empirical evidence that coerced drug rehabilitation not only doesn't work, but there might even be an increased risk of overdose after recidivists start using again and use at the dosage level they remembered worked for them, and now they've lost a lot of their tolerance, so they overdose. So, but I just from a moral standpoint, I don't believe you have a right to force someone into treatment. Now, if you see somebody lying on the street and you're worried that he might be dying, I think you have a right to call an ambulance and get that guy to the emergency room and get him resuscitated, but I don't think you have a right to incarcerate him as a patient. And Thomas Zaz has written a lot about this. You may remember reading his work. And another great libertarian icon. This is controversial, I know, and these are issues even libertarians argue about among our. We have differences over this too, like where do you draw the line?
Yeah,
but to me, basically, that's.
I think this is one of those conversations. This part of the conversation is really worth coming back on another day and taking on, because I think it really gets into that whole area of what you really mean by autonomy and how that interacts with consent. Because, I mean, if you think about somebody that's schizophrenic, then that raises a lot of questions about how truly autonomous they are and whether coercive hospitalization makes sense.
No, I agree. And this is a very complicated, thorny issue that you can't handle like in a couple of minutes of a podcast or something else. But and like I say, even libertarians argue over, okay, so where do you draw the line? I just think that the operating principle is that you need to respect autonomy. Now, you legitimately, when is a person losing their autonomy? If they're cognitively impaired, if they're a minor, if maybe their psychiatric illness is so severe they're having trouble making judgment at all and comprehending. So those are those gray areas.
Yeah. Well, come back. I'd love to talk about this for much longer because it's a really important conversation. Just as a final thought, that my concern, like I said, is that, do I have a right not to buy people's needles? Or do I have a right to my own storefront? Do I have a right to direct where public money is spent? That just is my concern, right? The autonomy argument works, but it's not applied consistently. And this is another problem I run into with some of my fellow travelers who advocate for harm reduction. Because like I say, a lot of them are on a progressive left. And and where we part ways is I don't think, just like you don't have a right to stop someone from injecting a drug into their own body, I don't have a right to make you buy that person the drug and the needle. Yeah.
So what I tell sort of allies in the harm reduction space, and a good thing about being in an organization like the Cato Institute, we're not aligned with any political party or faction, so we get to talk to everybody. And what I tell them is, look, you're going to have a hard time winning over people by talking about having the government fund safe consumption sites, as they call them, overdose prevention centers now, or needle exchange programs, because a lot of people, they may be able to buy the autonomy argument, but it still repels them so much they don't want to in any way feel like they're a part of it. So what I suggest to you is we do it as libertarians at the Cato Institute. I don't advocate for government funding of harm reduction programs.
Yeah.
I advocate for removing government obstacles to organizations that try to set them up. So like in about 5 states still to this day, if you wanted to go and hand out fentanyl test strips to people in part of your city where a lot of people are using, fentanyl or using opioids, and you just wanted to give them out so that people could test it to make sure to know what they bought, you can get arrested.
Yeah.
There are states where that's still considered handing out illegal drug paraphernalia. So what I tell them is, why don't you put the emphasis on removing all the obstacles? There are plenty of nonprofit, charitable organizations, church organizations that would like to help people who be happy to open up, needle exchange centers and all that. Just don't try to get people to accept that. You're going a bridge too far asking them to pay for it.
Yeah.
And some of the more practical-minded people I talk to say, yeah, I see your point. We'll stay away from that.
Yeah, and it's smart. One of the hangups, we keep talking, I'm sorry. One of the hangups that I run into is a lot of the same people who make these autonomy-based arguments for drug legalization. We're perfectly content for the government to say, you take this shot or you're fired and your kids can't go to school, and we'll lock you in your homes unless you come out for a politically approved activity, right? That to me is just beyond absurdity. And what it says is, I'm enforcing my preferences. I don't actually care about liberty.
Well, if you've read me, I'm consistent about this.
Yeah. So. You were very good on that. To your credit, you deserve great praise. Chuck, any final questions or thoughts? I don't want to keep you guys.
No, I'm good. I'm good. Here.
Okay, Jeff, give
I
the book.
just insist that we bring Jeffrey back because I really want to talk about autonomy and consent.
I love it. It's really important to discuss this in more depth. At Dr. For Liberty on Twitter, the number 4, not spelled out. What's the book title one more time?
Your Body, Your Healthcare. Healthcare is 2 words.
Very good.
And you could get it wherever books are sold. Or you can go to the Cato Institute and get it there, too.
There you go. Buy it direct. That's the best way to do it. Cut out the middleman. Okay, well, thank you so much for joining us. Thank you, everybody, for joining us for the show. At ACSH.org on Twitter, I'm at CamJEnglish. Follow us on TikTok, Facebook, YouTube. Matter of Facts, ACSH, hosted by our colleague, Anna Dalaski. She's doing great little videos and infographics explaining all these complicated topics. And as always, we'll be back next week. Thank you so much.